with NGOs to deliver mental health services in conflict settings. He's the co-founder of the Syrian Telemental Health Network, has coordinated the mental health response for the refugee crisis in the Eastern Mediterranean region with Doctors Without Borders, conducted mental health focused evaluation and training missions with the Red Cross, and has a regional mental health specialist for staff well-being in Latin America for UNICEF. Dr. Barquiloteo will join the discussion with his extensive experience working with refugees and with NGOs to deliver mental health services in conflict settings. Next, we have Hussein Ahmadi, the executive director of the Afghan Landmine Organization, Survivors Organization, was established in July 2007 based on the needs of persons with disabilities. Hussein Ahmadi was previously active in the field as a peer-to-peer support worker. In addition to advocacy, also has conducted research into access of persons with disabilities to education, parliamentary election access observation, and other pressing disability rights issues. He will present findings and insights from ALSO's recent assessment and report on impacts of COVID-19 on persons with disabilities and mine survivors in Afghanistan. Next, we have Ruth Bosamli. She is the Landmine and Cluster Munitions Monitor Research Specialist on Clearance and Contamination and Risk Education. Ruth has 25 years experience in international development and humanitarian mine action and has worked for international mine organizations and communities. She has also worked extensively in Southeast Asia and also in other parts of Asia and Africa. She will share fresh findings and innovative developments in reaching people at risk of explosive ordnance threats, including people in isolated and remote situations, with examples from the field and from COVID-19 responses. Then we have Darren Cormack. He is the CEO of the Mine Advisory Group, MAG, a global humanitarian development and campaigning charity, working in over 26 countries on 5 continents. MAG's work has helped more than 70 million people. Prior to taking over as CEO, Darren was the Director of Strategy and Government Relations with responsibility for the design, articulation, and delivery of MAG's organizational funding strategy. He will highlight that what MAG is doing right now to support its staff to ensure their well-being. We have also here with us today Jesus Martinez. He's a landmine survivor, human rights campaigner for El Salvador. Jesus Martinez is the founder of the organization Red de Sobrevivientes y Personas con Discapacidad that supports victims of armed violence and people with disabilities. He has been the president of the National Disability Council in El Salvador. He has also testified for the U.S. Congress on the needs for victim assistance in post-conflict societies and is involved in many international and regional movements. Jesus and I will present the initial perceptions from Latin American survivors as part of our engagement with the Monitor Survivor Survey. And I am Mariana Diaz. I work as a research specialist in the Landmine and Cluster Munition Monitor. I also work with UNICRI, the United Nations Interregional Crime and Research Institute, and I will be moderating this panel as well. So thank you all our panelists for joining today. We appreciate and we hope we have a very nice discussion with you at the end. So each panelist will have 10 minutes to present. We would like to leave all the questions at the end. Of course, you can use the chat to send out the questions right now, but we will read them at the end. Blue Jeans, the application that we're using, doesn't have a hand-raising function, so you can send all the questions through the chat. That won't be a problem. So first of all, I would like to start presenting some of our research and research findings. Me and Jesus will start with our presentation. Jesus, are you still here with us? Jesus? Okay. Well, I'll give you a quick introduction to the project that we did during these few weeks. So in the project, we asked for people to do surveys in 5 countries, so Chile, Colombia, El Salvador, Guatemala, and Nicaragua. However, this project is part of a bigger project. This was just the Latin American section. After the organizations and the individuals sent us their surveys, we had an online meeting focused on victims' assistance. And the findings we're going to present today, it's, let's say, like the main findings, but also we will share the overall experience of doing this project. Jesus? Jesus, are you here? Okay. Since Jesus doesn't seem to be here, I will start. First of all, I would like to talk to you about our overall experience, or what at least the people that were doing the surveys actually gave us as insights of the project during our virtual meeting. So first of all, we would like to say that we try to do this event to see how survivors and sometimes in general people with disabilities were going through this COVID-19 pandemic and how their lives have changed, because certainly we all had changes, but we wanted to see their perspective regarding medical assistance and other important topics. So the first comments that we received, first of all, is that they were happy that we were contacting them. They were feeling, or what they expressed is that there was a general feeling of abandonment from the government, but also from international organizations. They felt that there was not enough contact from these organizations, from the government, to see how they were doing or to help them to cope with this hard situation. So at the beginning, they were a bit confused also about the objectives of this kind of activities. They were a bit concerned about the results or what the information was going to be used for. But also, as we're seeing right now with Jesus, there are also other issues that are affecting. It's not only COVID-19, but we have natural disasters. We have security problems in the region that are also affecting alongside the COVID-19 pandemic. So those would be like the first impression that we received from them. The surveys were applied not only to survivors, but to NGOs that work with survivors, or to community organizations, and to representatives of the government sometimes as well. So overall, the survivors did express that there was some support from the government in certain areas. However, now with COVID-19, they have experienced an increased isolation and just difficulties accessing medical services, especially regarding rehabilitation services, psychologists, which they consider that's quite important during the pandemic. It's been really hard for them to cope with some things, and they say they cannot really access these sort of services. And in some cases, also the replacement of prostheses has been quite hard, since medical centers are closed, and they've been closed for almost the entire year, so they cannot really go on and replace the prostheses. In some other cases, like Colombia and Chile, for example, the territory plays a very relevant role, which means that, for example, in Colombia, they told us explicitly that indigenous communities are feeling especially isolated, because it's really hard to reach to those territories. And once the government or Campaña Colombiana contra Minas, for example, reaches, they are not able to communicate because they don't speak Spanish. So they suffer a very particular type of isolation, and they've been trying to reach to these communities, but it hasn't been easy. Also, because the distances between communities is quite long. They are quite remote. Sometimes the territory is not accessible, for example. In some cases, they have security issues where it's just not safe for them to actually go to those territories. In Chile, we could see something similar where it was really hard to reach the survivors, but at the end it was possible through phone or email, so it was solved, but physically it was really hard to reach, and that's, I think, one of the key points we can say, okay, this, even for making the service, it was hard to reach to the survivors, so they are actually almost completely isolated. Yes, as I explained before, there's this general abandonment sensation, not only from the government, but from NGOs, from the monitor. They think there's not been enough support, especially, like they say, like no one really has reached to them in a long time to ask them about their situation. So when we did this project, they were quite surprised. They were happy about it, but they did ask a lot why this hasn't done more frequently. Another point, I think another relevant point that we analyzed during this research is that there was a clear difference between the assistance received by survivors from the military and by civilians. Usually the military have their own medical services, facilities, and for them it's way easier just to access these services. And however, I must say, like in the case, for example, of Ecuador, the military are fighting for the civilians, so they are trying to make sure they receive the same medical attention, and they're trying to make sure everyone receives medical attention and obviously other services that go after the initial, at least, medical attention. But so we have this cooperation even between the military and the civilians for equal opportunities. They also express that political changes sometimes complicate the continuity in the provision of services or in the type of support that is given to survivors. They express that many times when they change government, or if something changes in the government, the programs stop or they are modified, so the aid that they receive, it just stops or it just changes. So they say that that's one of the biggest issues, because they cannot rely on a certain type or amount of aid because it changes a lot. So definitely that's a big concern. In some countries, political repression does not allow organizations to work correctly. So that's another big issue. It's that in some countries, landmine survivors and disability organizations, like they are getting targeted and they are not being allowed to actually perform activities. So that's isolating survivors and people with disabilities in general, because they are not being able to receive even the help from these organizations. In addition to this, of course, we have that medical centers are not really open and they're not receiving really basically any help from the government. So that complicates things for sure. And then we have another point that I would like to share with you is that some countries such as Chile, Ecuador, El Salvador, they all have issued new laws related to the rights of people with disabilities and survivors of conflicts, especially the laws that provide reparation and assistance to the victims of explosives. However, even if this represents a step forward, some survivors mentioned that they didn't receive enough recognition for their role in the process, because we had a lot of survivors and organizations that were pushing to issue these laws, and that they were there in the process, and they participated quite actively. And at the end, when the laws are enacted, they don't receive that recognition, and they think that the government takes credit for these laws, when most of the times it's civil organizations. So they feel that they don't receive enough recognition. And there's some hesitation about the actual effects of the laws, because most of them, they are quite happy. They think this represents a step forward, but they are not sure if these laws will actually be implemented. So they are waiting to see if this would actually reflect in changes in their own lives. So these are some of the main findings and main concerns that we found from survivors in Latin America. Jesus, are you here with us? If you want to share anything more.
Yes, I am here.
Okay. Yes. Would you like to share anything more?
You can hear me?
Yes.
Okay. Thank you, Mariana, and thank you all of you to let me to share with you. I want to start letting you know that our region is in middle of a strong hurricane. We are in a national emergency that the national authority are making their effort to avoid the loss of human life. Faced with this situation, we urge to our government, the authority of civil protection, requesting the guarantee the assistance to survivors and people with disability that they can be the priority in evacuation from the risk areas, and to be attending all their physical or emotional affectation if they lost their mobility equipment, that shelter have to adequate accessibility, that the communication information should be accessible for blind of deaf people, among other needs that they present as part of their inclusion. Even in the middle of this situation, I am very pleased to be part of this virtual panel and share with you the result of this regional survey that Mariana is speaking about it. And that allows us to identify the challenge that survivors still face for their full inclusion in the society. And as a fair considered point is that the most of the state's effort are insufficient, and it is for their inclusion, and it is understandable because the country, they do not have a specific budget for the survivor assistance. Also, it should be noted that some survivors recognize that health and rehabilitation service have improved in some areas, which is good, even if they are not concrete plans to reach a specific survivor, but the general population. It means that, for example, it is true some the rehabilitation, health service have improved, but in the urban areas, but not for people who live in remote or rural areas where the public service of health, rehabilitation, psychological support, on the program of reintegration economic. This kind of program not happen in the rural area. The survivor also continue to resent that those services and other are concentrated in urban areas, which put very, very bad disadvantage people who live in remote areas. And so it is difficult to reach them. It is obvious that the survivor expresses that they feel abandoned by the state, since in many cases the survivor only receive support by NGOs, by the NGOs. A country was identified that for example, I don't want to mention the country, but this country doesn't have any program for survivor or armed conflict. It is so bad, really. Also, it is important to recognize that some states have made important progress to creating laws, either for the specific benefit for survivor, as the case of Chile, or in general way for the entire population with disability, as the case of El Salvador. Let me tell you that based on pressure from the survivor organization and people with disability, the Salvadorian Congress approved a law for the inclusion of people with disability that will come into force in January 2021. The novelty of this law is that it obligates all public institutions to create a specific budget for the inclusion of people with disability. And so they cannot differentiate if it is a landmine survivor or another. No, people with disability in general. Also, this law create a tribunal that will impute fine and penalty to the people and the institution that compile this law. The penalties, economic penalties, are of amount of 300 as minimum until $2,700 American dollars in case they violence the right of people with disability. It is, for us, it's very important to have this kind of law, because we think that the authorities of people compile the law when it means that they could have a penalty, economic penalty. For me, it's very through these surveys, it's very gratifying to see how the survivor in Colombia and El Salvador are being organized in their municipalities or provinces. It's very good for the collective advocacy at the different levels. The survivor are part of the board of directors of the institution that are obligated to give the assistance for the survivors. So they are part of this. Some services are improving. I think that survivor organization movement is in a good way, because more and more survivor are joining to the advocacy activities. For example, from the Latin American network of survivor, we are also influencing and sending our demand to the state that they assume the more commitment in terms of victim assistance. Other main finding is that the survivor feel that the government should be more efforts for their assistance, but the important is that they recognize that the victim assistance, the inclusion is a right, and the government must attend the rights. And I think that these surveys allow us to find the common points that the survivor face, and it allow us to have a dialogue and to think what kind of action we should do to influence, to advocacy for the government. I think that I talk too much, Mariana, but Mariana say we have in the region, we have a common challenges like the health rehabilitation, psychological support program that in some areas, urban areas, it have improved, but no in the remote or rural areas. The service are so bad, and the survivor or people with disabilities have big program to the access to the public service to cover their needs. But for that, it's very important to know what the survivor think, how the survivor are doing to live, to cover their needs. And to that, demands more commitment to the governments. Mariana?
We lost you for a second, but thank you very much, Jesus. Thank you for joining us, and we hope everything goes well with now the hurricane. Stay safe. Well, now I want to give the word to Hussein, who's in Afghanistan, who's sharing the research on the impacts of the COVID pandemic on persons with disabilities. Hussein, if you want to share your slide, let me stop sharing mine. Hussein, do you hear me? Perhaps he's having some trouble with his connection. If not, we will start with Dr. Andre, who I think is currently in the US. So thank you for making this early start to be on the panel.
Oh, no problem. Okay, just a sec. All right. Um, okay, so thank you for having me. It's always exciting to. I do work a lot with victims of violence and refugees, and it's always interesting to kind of reach out to other other domains where it does. I do believe that the struggle is similar, although there will be some specifics to the working with survivors of landmines that could be different from working with other people. I was just taking notes from your presentation, and I think I will have just kind of general remarks about the same issues that we find in focusing on the mental health issues of special vulnerable populations and what to do about it. The the first theme that was very interesting for me, because this is something resonates with working with a lot of communities, is the sense of abandonment, the sense that uh, we are left behind. And this is an unfortunate reality that we see all the time. And part of it is really a product of how we set up systems of help and how NGOs operate. Many times we have to admit that we do have some popular topics, some trendy issues that everyone focuses on for specific amount of time, and which is good because that kind of brings everyone's attention. But then at the same time, at some point, either priorities shift. Many times this is driven by funders where they want to invest in the next 10 years. And you see that NGOs or even sometimes government kind of move on from their efforts of dealing with the issue, and they try to focus on other things. Um, in principle, I mean, there is nothing wrong with it because the idea is you help people who are most need, and then there is always someone who will be in need the next time. The issue is, I think, when the way we do the this type of work in medical and mental health, it's often, even if it lasted for 10, 15 years, it's often based on an acute intervention disaster response model where we put a lot of resources early on to try to help everyone, but we never really establish something sustainable or something that could last beyond our presence. And this is why we see it all the time when the attention shifts, when NGOs move on, then there is nothing left in place to sustain it, which is it's pretty unfortunate reality. And also it speaks about how effective we are. In many of the interventions I participated in, it was excellent, but it did feel like the moment the foreign kind of intervention moves on, there is very little on the ground to support it. So for me, the sense of abandonment, the way I see it, it means that there is no enough local resources, local support to sustain the services. So I think this will be a very interesting kind of start to think about the issue. Like, what exactly the issue of abandonment? What exactly the type of services people want? Medical, mental health, and all the other options, and also what are the local resources that we could set up in a way that could help. I heard that in some places the people who are more affiliated with the army, they will have a better services than the ones who aren't. So each country will have a specific kind of a setup to address this issue. But also I found interesting, because this is always we deal with it. Their surprise that someone is calling, and also their question about what are you going to do with this research? What are you going to do with the data? And I think this is something. I mean, it's very important. We often face the dealing with vulnerable population. Whenever we do a survey, we have to be very clear. Like, what is it for me? Is this going to change anything? This is why I think surveys, I mean, as you did, it's very important to not just focus on first we need to think about the issue from their perspective and not assume what the issue is, like what type of mental health issues they are dealing with and how do they want to deal with it. So to focus, we are less interested now in knowing how many people have depression, but more what's the general level of distress in the population, and also what the population think the services should look like. Because there's a common risk that often we have one approach to deal with everything in mental health. Sometimes people will have to fit in the way we provide services. We have, say, psychologists or psychiatrists who are providing mental health interventions. So it's like the context will have to fit the intervention rather the other way around. So this is why when we think about public mental health approaches dealing with vulnerable communities, not everyone needs to speak with a psychiatrist or a psychologist. Maybe only the ones who really have acute mental health issues or chronic mental health issues. But what's the intervention that makes sense for the entire population? So we start thinking, do they have, usually one of the most kind of common ones are, do they have local support, and do they have local support in the forms of say this peer support? We do a lot of like low intervention, low complexity in the base of the pyramid, like the pyramid with the public health interventions, where you have the low intervention in the bottom of the pyramid, and that's when you provide things like low intervention mental health treatment. You train people, so you come up with a peer support group. So someone from the community is trained on providing some form of mental health interventions, and then slowly you start kind of trying to provide more complex services, ending in the end with the psychiatry and the clinical psychology. And often not just the type of intervention, but also what the type of professionals we have. In places I worked with when we didn't have psychiatrists or psychologists, so you start training peer support. That's the first level, and then the second, you start finding who is in the community, maybe have a bit more advanced training in mental health that you could take advantage of. Because the issue of the access is real, and we will never be able to cover all regions with appropriate mental health services. So we have to kind of rethink the model of specialist with client versus what local resources I have in the community, and how can activate this to provide acceptable form of mental health treatment. So we did this a lot of, say, in Iraq, where they had a lot of university graduates, and they had a lot of psychologists, not clinical psychologists, who were somehow trained, but they didn't have enough skills to provide clinical services. So we kind of concentrated, instead of trying to bring psychologists from the outside to provide the services, and then maybe the psychologist is going to leave at some point, to try to create this local capacity, working with the community. The good thing is, now with the telemental health options, and everyone seems to be open to it, we definitely have much more ability to provide services and access to communities. But in the end, you end up having the same problem. We don't have enough psychiatrists and psychologists to deal with everyone. So we're gonna always have to find alternative ways to deal with people. The other issue is, I mean, we think always about, and I don't know if you or someone else in the survey did ask some questions about what their specific mental health needs. Because often, I mean, the common barriers that we see a lot, and sometimes some things you mentioned, is language barriers. We have people who speak maybe a local language, and we have mental health clinicians who don't speak that language. So we dealt with this a lot in the Eastern Mediterranean region, and it's been solved sometimes by training local people to provide the services, or sometimes having cultural mediators who could intervene. The distance of isolated communities definitely have a harder time to get services. So that's when you start thinking about providing some telemental health options, security in terms of accessing these places. But this is only just the technological kind of fix. The other issue with barriers is what does the population really want? What type of services do they want? We always assume that anyone who has mental health issues needs to speak with a psychiatrist, but maybe not necessarily. I had a very interesting encounter. I was in northern Iraq working with the Yazidi community, and Yazidi community tend to be very tight socially. They sit all in the same place, and the family, it have a sense of like the bigger family. And I was speaking with a young gentleman, and I was doing kind of my usual mental health assessment, and it did seem that he had some anxiety, chronic anxiety. And when we're talking about what to do about it from an individual perspective, he said that how could I improve in my anxiety if my entire community is affected? So the idea is that sometimes in our Western model, we think a little bit more of an individual perspective versus there is also a community level that sometimes missing, that we cannot treat the person unless we also focus on the community. So what we did with this Yazidi community, we came up with basically what looks like from the outside like a group psychotherapy, where you have a bunch of people. So in that case, there were a bunch of men sitting together, and we led a group discussion about anxiety issues and how us as a community could deal with it. And for them, this made much more sense than having to figure out your anxiety solutions just one-on-one. And I think this is also is more empowering because you are helping the community to help itself, and also more sustainable because these type of things will stay even after you pull out the resources. What I find interesting, and unfortunate that with COVID now, everyone is focusing on mental health, and often the results are not the results that there's a lot of stress and anxiety, and there aren't that many services. It's not surprising. I think what's happening is COVID is uncovering. It's kind of acute and chronic stress. People who are not doing well with COVID are people who are not doing well in general, but now with COVID, we are paying attention to them. So this is an opportunity for us not to. COVID will disappear at some point, and we're gonna figure out a treatment in the next couple of years, hopefully before, and then people move on. But the issue is the chronic structural issues in terms of providing health and mental health will stay. So I do think that the main issue will be to try to focus on really what's going on underneath this, not just focusing on COVID and how we could provide an acute intervention, but also thinking in a sustained way. How can we solve these issues, not just for COVID, but also for future issues as well. I see a question. I'm not sure if I should answer the questions now or we could wait till the end. But since for this question is very important, I think to the topic. So usually what we do is, at least in my work with Doctors Without Borders and with the Red Cross, we use local clinicians. We are trying to push a model where it's rare that you will have a Spanish psychologist treating an Iraqi patient alone. So the one option is we use someone who's a cultural mediator to be able to talk with the patient and understand their perspective. Second, we use a lot of local mental health practitioners. So say a Spanish psychologist will supervise an Iraqi psychologist dealing with an Iraqi patient. And in this way, you use the Iraqi psychologists as a way to understand the local issues. And also you have to be, as a psychologist or psychiatrist, you have to be, like willing to consider different views and sensitive to what are the differences between different cultures. So my questions to the Iraqi psychologist will be, what does he mean by this? Why is he saying this the same way? What's something about the way we talk about this this depression in Arabic that's different or similar from the way I will understand it? So that's usually how we work. We work a lot with the local resources to understand the context. Traditional healers, it's always a complicated topic. I worked on this issue in Ghana with the prayer camps, in Iraq, in Syria, and also in Latin America. Not every in some communities, traditional healers tend to be open to the idea of working with us, and also us working with them. And in many cases, you could actually develop very productive relationship, in the sense people are going to traditional healers anyway. And also not to feel that we are in competition with them. My experience in the Middle East was fairly positive. People will go to a sheikh or imam for consultations, and often after they do their thing, they advise people also to seek mental health help. That helped by doing an outreach efforts, and people understand that these are kind of two sides of the same coin, and often it's not necessarily have to be we have to work in against each other, but many times we could work together. In Africa, at least where I worked in Ghana, it was a bit more complicated because the prayer camps where people will usually go who have mental health issues, it's a bit more complicated issue. It's a big business, and some of them were hostile to any mental health understanding. Some of them were actually interested. So I think it's the idea is how you come with a model, you rely on local resources to for guidance and help. You are sensitive to a different points of view of mental illness, and also then you ask the people, like, what do they want? I don't assume that everyone wants to be in therapy and medications. Like you kind of ask them what type of service could be helpful. The one common issue we end up with is, and it's a common theme, as I said with the Yazidi man, the mental health aspects of oppression and social isolation. It is true that sometimes being oppressed in a system will create depression, will create mental illness. Now, I'm from the orientation that I don't wait, and in that case, I don't assume that this depression is clinical depression and doesn't have anything to do with the environment. So I only need to focus on the depression. But at the same time, I don't assume that I'm not going to focus on depression till I fix the oppression, right? Sometimes these social issues takes years to fix, and there is nothing wrong with focusing on mental health issues. So I do think, like, we in some societies, we have to think part of the reason of the mental health presentation is related to social issues, and we need to address them at the same time. So we provide mental health services, individual services or group services, and also we provide social work, social workers for advocacy, for support, for addressing also all the social issues that could be affecting mental health issues. I think I'm reaching the end of my time. Is that correct? Okay, and so any other questions, I'll be happy to answer during the Q&A.
Perfect. Thank you very much, Dr. Baraki. Hussein, are you with us?
Yes, I can hear. I am available. Yes.
Okay, perfect. Then, next we have Hussein in Afghanistan, who's sharing the research on the impact of COVID-19 pandemic on persons with disabilities. You can share your presentation as well with us if you want to.
Thank you very much to all for organizing this important side event. Good afternoon and good morning to all. I want to have a brief about also assessment on the impact of COVID-19 on persons with disabilities and mine survivors in Afghanistan. Unfortunately, the COVID-19 pandemic impacted all over the world, including Afghanistan. Many people lost their lives and affected economically. To prevent the spread of COVID-19, the Afghan government applied restrictions from 8th March till end of May 2020. That included shutdown of all education centers and business institutions. The movement restricted in all countries. The lockdown put a negative impact on all sectors, yet the COVID-19 pandemic increased the challenge of persons with disabilities and mine survivors disproportionately in employment, loss of incomes, shortage of foods, decreased access to health services and education. To find out about the challenge of persons with disabilities and mine survivors, who make 13.9% of Afghan population based on Asia Foundation report in 2019, and the Disability Rights Organization during COVID-19 lockdown and restriction also conducted an assessment with the participation of mine survivors and persons with disability-focused organization. The main objective of this report was to find out, one, the access of land survivors and persons with disability to services. And second objective was to know about operation level and collaboration and challenges of disability rights organization during COVID-19 in Afghanistan. In other words, we can say these assessment findings will help us to identify the gaps and needs of survivors for better improvement in future. Based our assessments, the main challenges of persons with disability and mine survivors were unemployment, shortage of daily food, psychological problems, increasing domestic violence, and decreasing access to health services, including rehabilitation services. This assessment shows that during the COVID-19 lockdown, the majority, 58% of the respondents with disabilities and mine survivors said that unemployment was their main problem. Shortage of free staff, 38%, and psychological problems, 34%, were the second major problem during COVID-19 lockdown. Also, the lack of awareness and right information about the COVID-19, 29% was with disability, as mentioned in this assessment. In addition, persons with disability and mine survivors were not prioritized in distribution of aids like bread, foodstuff, and package that provided by the government during COVID-19 crisis in Afghanistan. Moreover, during COVID-19 confinement, the disability rights organization faced challenges in implementing their programs. They had to reduce their services by 25 to 75%. Some of them ran out of funds and shortage of budget, that did not have the capacity and resources to reach out to persons with disability, especially those living in rural and remote areas. As well as there was no appropriate collaboration and coordination between the disability rights organizations themselves and the government agencies in their response to COVID-19 with regards to ensuring persons with disabilities get the right support that government is obligated based on the UNCRPD. Regarding supported which persons with disability received by government and other private sector civil society organizations were brought by government, and also some food stuff like oil, rice, or other things. Awareness package, health package, and other things which is needed for hygiene to prevent COVID-19. But respondents said that this support was not enough to persons with disability. Based on these mentioned challenges that persons with disabilities and mine survivors, including disability-focused organizations, also has some recommendations based in these findings to government, donor agencies, civil society organizations, and disability rights organizations. 1. The government should provide timely livelihood support to all persons with disabilities, including mine survivors, to reduce the most immediate impact of COVID-19 among them. 2. The government must ensure providing accessible information on COVID-19 pandemic to all persons with disability, including sign language, braille, or other accessible means and formats. 3. The Minister of Public Health should priority to persons with disabilities, including mine survivors, in getting required health services during and after the pandemic. 4. The Minister of Public Health should provide peer counseling to mine survivors and persons with disability to reduce the increasing psychological problems, including domestic violence. 5. The Disability Rights Organization should have collaboration and coordination mechanisms set up for COVID-19 pandemic and other emergency incidents. 6. The disability rights organizations should have close collaboration and coordination with government to protect the rights of persons with disability and mine survivors. 7. The international donors and the United Nations agencies should consider allocating a specific budget to local disability rights organizations to support the mine survivors and persons with disability during COVID-19 and other humanitarian natural disasters. 8th, the government should give priority to persons with disabilities and mine survivors vaccination process if become available in Afghanistan. 9, the International Disaster Management Authority of Afghanistan and at global level should include the special needs of persons with disability in their policies and program, especially in its mitigation plans. Thank you very much. This was the main finding of also assessment about impact of COVID-19 on persons with disabilities and mine survivors in Afghanistan. If there is any question, please share through chat box and I can brief for you.
Thank you very much, Hussein, for your very interesting presentation. If there's any question, you can just put it in the chat, as he said, and then we'll read them at the end. Right now, I want to welcome Darren Cormack from MAG, who will present another perspective on mental health and well-being regarding reaching staff of MAG. Welcome, Darren.
Thank you, Mariana. Thank you. Thank you, everybody. Nice to be with you. Good morning, good afternoon. Really today I want to reflect on some of the work that we're doing from the perspective of well-being, from very much looking at it through the lens of the recent COVID pandemic. But as Dr. Andre said earlier in his presentation, I think we've got to look at what we can draw from this experience and apply it in a more sustainable way to affect positive change, really, both in the organizations we're all a part of, but also the sector in which we work. So to introduce myself, I'm the relatively newish CEO of MAG, but I've been with MAG for some time in the sector for 10 years or so. The fundamental kind of responsibility when it comes for well-being for us is driven by the responsibility we have as a duty of care, and I think there's no greater responsibility than the duty of care we have for our staff. MAG, alongside many other organizations, has thousands of staff working in a range of contexts around the world, and seeing well-being, mental well-being, physical well-being as equals is a fundamental kind of shift we need to make in society and in our organizations. So the starting point is seeing our work through that perspective. I took over responsibility for MAG as CEO pretty much at the start of the pandemic, transitioning into the role in late April, early May. The ambition, I have to connect the organization at a time, of pandemic has been really a key thread to trying to deal with the risks and uncertainty that we were facing. If you think back to where we all were in April and May, late March, April, May, the uncertainty that we were all facing with the unknown influence of a global pandemic and what it was going to do to society, the risks we felt we were facing as a result of the isolation due to global travel constraints, the uncertainty around funding. It was a very anxious time for a lot of people. It continues to be an anxious time for a lot of people. There was a lot of uncertainty back there. So fundamentally, we were all learning here, and I think sharing the learning as we're trying to do today is of vital importance to the sector. As we took over really the responsibility of leading MAG in a time of a global pandemic, set out to do three things as an organization, as our commitment to staff. The first, ultimately, as we're talking about today, is to protect staff, that responsibility for the duty of care for staff, their exposure to COVID, to the risks of their day job being heightened as a result of working in a pandemic, the impact of being isolated. That kind of duty to protect our staff was the first of three priorities that we set for ourselves. The second was the communities that we were serving as an organization. And ultimately, there are 60 million people around the world impacted by landmines. And a global pandemic hits the poorest hardest. And our responsibility, therefore, was to continue to ensure we had that mission focus on those people impacted by landmines, cluster munitions, and exploded ordnance around the world, and getting back to work as quickly as possible in partnership with our donors, in partnership with our partners, to get back to work as quickly and as safely as possible. But that obviously created uncertainty around how we could do that. So that was the second of the 3 priorities. And the third, ultimately, is the sustainability question, is how we kind of come out of this pandemic and build back better as an organization. And that obviously is cliched a bit, but as we were hearing about earlier, this pandemic will go, we will find a solution to it, but how do we draw from the experiences here? So that's the context in which we were taking over and dealing with the pandemic, and some of the the sort of basis for some of the reflections I want to just share in the few minutes we've got here today. The first, when it comes to sort of addressing issues of sort of mental well-being in an organization, is, I think, to talk about it, is to create a context, to create a culture where these issues are being discussed and are being discussed openly. For us as an organization, we are and want to talk about it more internally. I'm glad of the opportunity to reflect on it externally today, and have sought to do so with bits and pieces we put out via social media to kind of promote a conversation on these issues of mental health and well-being. Much like the challenge of being a more inclusive and diverse organisation in the sector, these are the things that we want as a responsible sector operator to talk more about. So the first, really, as I say, is to create a context and a culture where issues of mental health are being discussed and well-being are being discussed. And that's been really key. So setting that out has been a priority for myself and the leadership team at MAG to create that. And that comes by, what do you talk about? How do you provide the information for staff? How do you create a dialogue on these issues? And we're supported by some great colleagues in our HR team who've done a lot practically to help us. But that overarching, what are you talking about in an organization, the emphasis you place on things as a CEO or as a leadership team, I think really obviously helps to inform and influence and develop culture. But we were doing all of this in, at a time where there is isolation for people in how they work, isolation because of the protocols in which they work in a country, isolation because the country in which they are working might be locked down. I've been a CEO of MAG nearly for 6 months, remarkably, and I've probably been out of the house 3 or 4 times, and that wasn't necessarily the context in which I thought I was coming into. And this conference today is a reminder that, we're all adapting in that way. So there was, a need to connect people who were naturally and practically going to be isolated. So one of the key principles, as well as influencing and setting culture by what we talked about, is how we talked and finding ways to connect the organization. So we got as close to the 5,000 people in MAG, if you like, feeling like one organization, building one MAG, if you like. So improving the frequency of how we communicate as an organization has been key. Transparency has been key in how we communicate, finding different ways through multilingual channels, through sharing newsletters, through all of that, creating ways to just provide people assurance. Because ultimately, when there's a lot of unknowns, you can address the authenticity and transparency with which you're addressing the unknowns in an organizational context, I think, can give people a lot of assurances. A lot of the solutions, as Dr. Andre is saying here, are not experts. We're not experts in dealing with issues of mental health or depression in that way, but we're looking at trying to help provide assurances and support. So having an internal communication style where we were authentic and open and as transparent as possible about the risks that we might be facing, whether it became, about the uncertainty of the pandemic, and creating a regular routine update for staff on the situation, status of programming, etc. I think that's provided a lot of assurance for people, and it is that assurance, that sense of being spoken to and issues being addressed, I think, has been helpful for us. So creating a culture and finding ways to improve communication to help fill in the blanks, if you like, in an organization. They're the general things, but then, very practically, we knew that there were things we needed to do to support staff, either in this context or more generally. So there's a few things I'll just refer to that we as an organisation have done, and obviously able to provide more information or take questions. The first, fundamentally looking at it through the lens of kind of operations, has been quickly adapting and training and supporting staff to get back to operations as quickly as possible and as safely as possible, in line with best practice, with standards, and with the requirements of our host governments, of whom we are a guest. That has been key. I won't focus as much on what we've been doing at an operational level, seeing this more about the context of well-being, as per the brief, but getting back and having the support of donors to be able to adapt, to innovate, and to respond to the new challenges being presented from a COVID perspective has been really key, and that partnership across the sector is to be applauded. The training and protocols around that to support health and welfare have been critical. But then it's really just about how we target that particular sort of resourcing of well-being in an organization. So some of the things that we have invested in to try and help staff have been providing advice, access to information, resource and guidance in a number of ways. Some of it has been around supporting staff to equip them with webinars or training and access on remote management of staff. There's a lot of people who are managing staff virtually, and we need, our responsibility is to ensure the support and effective management and leadership of staff, and training people so they can adapt to a new model, a new way of working has been key. So sharing tips, sharing best practice from other sectors, technical training on some of the IT that we're all adapting to, and many of us still adapt to these new platforms that we're all developing. All of that is trying to make it as easy as possible to effectively succeed in a context there. So some of that training sounds very general, but I think can be helpful. And then sharing webinars and external support for issues of well-being and making available resources and training forums for staff has been important. Across the organisation, we have invested in the appointment of some mental health first aiders in the organisation. Now, I think every organisation would be familiar with the concept of having a health and safety official for people's physical well-being, but to do so and to invest in individuals from a mental health perspective, to train them to support their colleagues, to know what to look for and to be a confident at a peer level has been a really important thing for us to do as an organisation and strengthened us. We've also put investment into an employee assistance program, which is a third-party resource platform where people can go for advice on issues around physical or mental health, and whether it be support resources, whether it be particular support on incident management, whether it be support we could find for counselling people who are dealing with bereavement. So all of that is as MAG as an employer trying to provide resources to support staff who might have specific issues or just generally are not okay, which is okay to be not okay ultimately here. And then connectivity, as I say, finding that overarching approach to continually update the organisation as to where we are generally, or in the context of the COVID pandemic, as emphasis was placed back in March and April. But also continue to find that best practice to connect the organisation laterally. So finding sort of more informal arrangements, drop-in forums, social chats, setting up virtual kind of societies, quizzes, sharing things. Those things that for people who are working remotely, you might be just the one member of staff in a country, such as the model we work in some contexts where we're supporting, national authorities. You could feel incredibly isolated, but if we're setting up a context that is you can pop in once a week to a certain, a certain weekly meeting where you're just connecting with people. And having popped into a couple of those, it's really informal, but helping to connect staff who might otherwise not be, spoken to day in, day out, such as the isolation in which we're working. So I said I keep it short, but there's some of the practical things we're doing and the overarching sort of shifts in principle we're trying to make as an organisation as part of a member of the sector here. And fundamentally, the well-being of our staff is directly relevant to the success of the mission of the sector we're in here. As a sector or as an organisation, there's 60 million people need our help. Many millions have already been helped, but they've been helped by people who are day in, day out, persevering and committing themselves to clearing landmines. And how well they do it is directly linked to how well they're feeling. And therefore, that link, I think, is critical for us to acknowledge. And one that we are doing, and hope that some of those reflections can help others benefit. So that's it, Mariana. Back to you. Thanks for having me.
Thank you, Darren. Yeah, very interesting, and I think you offer quite a different perspective, but something we should definitely consider in this context. As our last panelist, we have Ruth with us. Ruth will address perspectives on reaching communities at risk, an integral element of this topic. Hi, welcome, Ruth.
Hi, Mariana. Thank you. It's nice to be part of this panel. They've been really interesting presentations, so I hope I can keep up with them. So in my work as a researcher for the Landmine Monitor, obviously I get quite a good global perspective of what's going on. So what I'm going to do today, I'm going to frame my discussion within the COVID pandemic, as I think most of the presenters have done, and look at how risk education operators have adapted and adjusted to meet these almost unprecedented challenges in terms of providing risk education. So I think as a first point to make, and I'm sure that most of you know this very well, but even when we're in the midst of a global pandemic, people are still at risk from landmines and other explosive ordnance. And in some cases, the pandemic has actually increased vulnerabilities of many people and communities. We've all seen this, I think, in our own country contexts, where poorer groups, more marginalised groups are more dramatically impacted by this virus. So including here in the UK where I am. But in countries where there's landmine contamination, increased vulnerabilities can of course increase the risk of people being exposed to landmines. So just to give a few examples, I'm drawing on a survey actually that MAG conducted in Myanmar at the beginning of the pandemic. They actually found that about 62% of villagers in the areas where they were working said that the restrictions imposed because of COVID were impacting on their livelihoods. So this would be through, for example, an inability to sell products at market, to pick up work as labourers or to buy goods. And obviously a narrowing of livelihood opportunities, particularly for poorer communities, forces them to undertake options that are perhaps higher risk that they may not otherwise take. So for example, foraging or hunting or gathering forest products in mine affected areas. And again, also with the large number of refugees and IDPs that we have globally at the moment, many of them are more vulnerable with this outbreak of COVID, and it increases the likelihood that they may try to move or return home. So, for example, in Lebanon, the COVID pandemic and the continuing decline in the economic situation there has raised concerns that some of the refugees there may try to return to Syria before it's safe for them to do so. So there is a real sense that this pandemic has heightened existing vulnerabilities, and that, of course, in terms of mine risk, makes it very important that we can still reach these people and provide risk education messages that can help to save lives. So risk education itself has been impacted. You know, a lot of what Darren was saying, organisations have a duty of care to their staff. They have to protect the staff, make sure that they're working in safe conditions. For risk education, one of the most common delivery methods tends to be through interpersonal or face-to-face meetings and community gatherings, because it can help to build rapport and trust. It can be conducted in local languages, and it allows for two-way communication. But obviously with the outbreak of the pandemic, many of these activities were either suspended or stopped. There was concerns that risk education teams going into areas could be a vector for the virus, or that the teams themselves could contract the virus. And also the restrictions in many countries actually just prevented meetings and gatherings of people. Schools were closed, so risk education that's provided in the schools also stopped. And there was often sometimes travel was prevented between different provinces or municipalities within countries as a way to curb the spread of the virus. So risk education has had to adapt. They've had to think on their feet and develop creative and collaborative approaches, which have drawn on existing risk education delivery methods, but also have expanded and explored some new options. So just to give some examples, and as I say, it's really going to be a broad brush stroke of examples, and I'm sure that there are some operators here like Habib, who's been working in Afghanistan, who could give some more in-depth examples of how they're approaching risk education during the pandemic. But in areas where risk education was still possible in terms of face-to-face delivery, many risk education operators began to integrate hygiene and awareness messages into their risk education delivery. So things around washing hands, physical distancing, recognizing symptoms. So we heard that a number of operators were doing that, and many of the messages that they provided picked up on synergies between hygiene messaging and risk education messaging. So things like the comparison between not touching surfaces or other people, staying away, which related also to some of the messages that are used in traditional mine risk education. And I think one of the key things is this reinforcement that when people are anxious and they have concerns and it's a very complex time, messaging needs to be really simple. It needs to be very straightforward. As a recipient myself of health promotion messages during this pandemic, I can tell you that I can remember the hands, face, space that they're giving in the UK, but I can't tell you any more about the more complex messages around how many people are allowed to meet up and where they can meet and where they can't meet. So I think that sort of idea that messages need to be very simple, very clear, and very practical to help people in these situations. We also saw risk education teams repurposed to deliver hygiene products in addition to COVID-19 messages. So that happened in many countries, Cambodia, Iraq, and also Myanmar again. So basically using the logistical and the organizational expertise of organizations and the risk education teams to help get those materials and messages out there. Again, when people were able to conduct face-to-face sessions, they also talked about how they adapted those sessions to maybe hold them for shorter periods of time than they would normally hold them, and to hold them with much smaller groups, such as household groups, so that again it would prevent the spread of the virus. But of course, there's been a lot of exploration around alternative means of disseminating messages remotely. And in a way, this was being discussed already and implemented within risk education programs. But in some ways, I think the pandemic really added some impetus to this and pushed it along a little bit more. So we've seen many risk education messages and also COVID messages disseminated through social media, mobile applications, text and voice messages. And I've also seen a cross-fertilization of sort of the way that messages and different apps have been used. So, for example, WHO has a COVID-19 app where you can look up information and ask questions. And that was being discussed within different circles around how that could be adapted for a risk education approach. So it's been quite a fertile mixing of messages and learning from different approaches from different sectors. Obviously, in many countries, many contexts, digital media, social media doesn't work. Mobile applications are not going to work. So we've also heard about just a scaling up of some of the mass media efforts that have long been used in risk education. So, for example, I think in Afghanistan, really promoting messages through TV, radio, and also through vehicles with loudspeakers mounted on them. So very sort of basic, almost means of communicating messages, but ones that they can do and do safely within this context. I guess what's also interesting and also perhaps links to some of the discussions that some of the other speakers have talked about in terms of really linking to sustainability of approaches and community-based approaches. We did see with some of the operators the value of actually building the networks that they had in communities, so risk education networks, community volunteers, who have been able to continue providing risk education messages within their communities when the NGOs and the international operators have not been able to visit. So I think this is interesting, and it would be really good to think more about that. We've seen community focal points employed to pass on messages, and also to pass on messages sometimes digitally through WhatsApp. They can be the key focal point to then pass on those messages. Organisations, of course, like ICRC have really been able to capitalise on their network of Red Cross and Red Crescent volunteers. And some organisations have actually conducted remote training of focal points and village leaders for delivery of basic risk education and COVID messaging. There's also been good examples of better integration with partners, with health programs, other humanitarian operators. Again, several examples around, but just to give one, because I know time is quite short. In Thailand, village health volunteers were trained to provide messaging in COVID and basic hygiene messaging. And so they were teamed together with the risk education teams from the Thai Landmine Action Centre, so that they could provide both risk education and COVID messages in some of the border regions where there are a lot of movement of migrants, labour migrants, and also where there's a lot of contamination. And I know that other operators have also been working very closely with UNHCR and other humanitarian actors to identify the situation in some of the refugee and IDP camps and to agree on the best way to reach people there. And I think, you know, as a global community of risk education practitioners, the COVID crisis has brought about a swift and united response, which has really helped to promote learning, innovation, and to sort of accelerate knowledge. And I think also to provide that sort of moral support for organisations and even individuals who are finding their way in countries and trying to do their best to support communities who are in these sort of isolated situations. So the EOR, the Explosive Ordnance Risk Education Advisory Group, has done a lot of work around collecting resources, and also kick-started the process by holding a webinar back in April to begin to share experiences and lessons learned. And this was followed by a regional webinar in the ASEAN region in Southeast Asia to again discuss the response of risk education to COVID. The community of practice, the International Mine Risk Education Working Group, again has been really active with its members in terms of discussing different approaches and sharing advice and experience on how they're adapting risk education approaches during this period. And then I think it's also interesting that some of the studies that have been ongoing, such as Geneva Centre, for example, was conducting a study on innovative technologies and methodologies for risk education. So they took the opportunity to really look at the emerging work and adaptations coming out of the COVID response to document that. So I think there's been a lot of support and innovation and discussion around this. And I guess when we think about the future, there are still uncertainties. We're hoping, of course, that the pandemic is not going to be with us for too much longer, but it may continue to resurface in coming months. It may have quite a negative impact on funding. It may also have an impact still in terms of people being able to go out and reach communities as they've done in the past. So I think that there's a need really to document a lot of the learning that's come out of this response during COVID for risk education and also for some of the other sectors. And again, as many of the speakers have already said today, to sort of, you know, adapt to this new reality and perhaps take a stock take about, you know, what are going to be the sustainable methods for providing risk education in the future? How are we going to be able to support communities and remote communities? and give them the information they need at the time that they need it. So I think with that, I'm just going to finish so that perhaps we do still have some time for discussions and questions. Thank you.
Thank you, Ruth. Thank you very much. Yes, so now if anyone has some questions, you can either raise your hand. It's at the bottom of the people chat. Well, not the people section. You can raise your hand there, or you can post it in the chat as well. There's a comment. It says, well, it's in the chat. I am Ako Aziz, a director in Iraqi Kurdistan Mine Action Agency. I see, and it's a reality in most of the Middle East countries and the poor countries that the traditional healers and religious persons have a big role in treating people whom are suffering from mental and psychological disorders. Sometimes the treatments are successful and sometimes they fail. In Iraq, and especially in the Kurdistan region, this status of dealing with patients is developed. Most of the people are dealing with specialists in mental health and psychology. So thank you very much. Also, if any of the panelists has another intervention or something they would like to ask to another panelist, you can do so. Yes. Andre. Dr. Barkil, do you want?
Yes, I'm here.
You do.
Oh, I'm sorry.
Thing or?
Yeah, no, so I don't think it was a question. I agree with him, and that was my experience in the Middle East, that we often were able to work with imams and traditional healers, and I used to get referrals from them. We never had an official outreach program in the areas I worked, but often I will see patients because the imam referred them to us. So it felt actually there was a good understanding of mental health and different aspects of the medical and the spiritual. But that's not often the case. So yeah, that was a good experience.
Okay, thank you. Well, I have a question for Darren. We can wait for other questions, but for now, well, you talk about this platform of resources, of how MAC supports their staff. So do you get feedback from the staff on how they find this support? And another question would be, could you imagine this as something that can be replicated in other humanitarian mine action contexts?
Yeah, I mean, the feedback is still early days right now. We're just introducing new tools and platforms. So we haven't got anything specific by way of feedback, but generally I think that sort of sense of availability of resources if you need it, that support network if you need it, does provide some reassurance. So I think that's been the kind of key feedback so far. I think that the thing to acknowledge with the kind of making available resources like that is the risk of digital exclusion. Let's be honest, there's still many people for whom an online platform where they might be able to go and seek assistance, that might be helpful if you're in a virtual context where you have good access to the internet, where you can make yourself accessible in that way. But if you are if you're clearing landmines in a remote context, or if you're a driver in DRC working for there are still there's still issues and prejudices ultimately in making these sorts of resources available. So a big emphasis is also about how we look at local solutions as well as a global approach to adapt them practically to the context and also culturally to the context, as Dr. Andre referred to there, and somebody commented on the chat. Those cultural considerations are really vital. So we have to take a think global, try and act local approach to this as well. I think that would be my main reflection so far. Thanks, Mariana.
Okay, Thank you. Any other questions? Because I can ask something to Hussein. I think Jesus had to leave, but Hussein, are you still with us? Or maybe Hussein had to leave as well. Okay, so Ruth, can I ask you a question, Ruth?
Sure, go ahead.
Thank you. How can we leave a capacity for response to risk in remote communities, and does this require ongoing external support and training?
It's a really good question, and as I say, I think that there is some work being done towards this already with sort of training of local people as community focal points. A long time ago, I also worked on a program which did basically build up risk education capacity at a local level. But often they are set up by NGOs, and to develop a sense of, I guess, of that you're serving the community rather than the NGO is one of the challenges that these sorts of programs often face. And also, I think it needs to be done in a broad way rather than just selecting one person, for example, as the key resource person within a community. It needs to be a number of people so that you don't get gatekeepers and sort of power issues going on. So I think that we need to really think much more about how we can do that, because I think particularly for remote communities, for indigenous communities, for communities, for example, like the Yazidis in Iraq, who communities that need to be able to trust people. It makes much more sense that they have people from their own community being able to support them and to provide that support on an ongoing basis. So I guess for me, I would really like to see sort of risk education think and work more towards that, as well as to some of the, the more high-tech solutions that we're also looking at. I hope that answers or provides some response to your question anyway.
Thank you. Okay. Well, we have a comment from Denise here. Our experience was that mine survivors and others, very poor Amazedius with their resilience and alternative ways of catching fish and frogs for food. Well, if there are not any other questions, I think we can wrap up the discussion. I would just like to comment or to point out some very interesting comments. I think what we learned from this experience and from analyzing the changes during the COVID pandemic is that, first of all, as Ruth mentioned, that it's been accelerating knowledge and changes for sure. But also Darren mentioned interesting things like that we have to not just take the changes during the COVID pandemic, because this was just one event, but actually adapt to eventually have new approaches for communicating with each other and solving these issues. And in this case, of course, tackling issues like distance. But I want to thank all our panelists for participating today. And thank you for joining.
Thank you. Thank you for having us.